Yeah, it's had a big impact here. We have in Ohio, where I'm located in Cleveland, we're just at the very start of the local pandemic, which started a couple of weeks ago. And the governor of our state was one of the first to close the school system and then have a stay-at-home policy for individuals doing non-essential work, and all non-essential businesses are closed. And the early data we have suggests that that kind of social distancing is going to bend the curve. Having said that, it has completely disrupted our day-to-day medical practice. So the number of surgeries that we are doing across our system has fallen by 75%, and we are restricting doing surgery only to those that are essential. So those are patients who are trauma patients, or fractures, or acute infections, acute appendicitis, infected kidney stones, and really advanced stage cancers, people who it would not be safe to postpone even for a few weeks. And it also has not only cut down on the number of patients that we see every day by about 50%, but it's shifted the way we interact with patients. So we had this nascent virtual platform to interact with patients and do their routine medical care for things that don't require in-person physical examinations virtually. And we set as a goal as an institution this year to do 3% of all the visits we do virtually. And that's really been turned on its head now. The vast majority, probably 80% of the interactions that we have with patients now are through these virtual platforms. And that has been allowed in part because of an ease of government restrictions. In the United States, we have a law called HIPAA, which makes personal health information protected, and anybody who violates that or releases it inappropriately is subject to criminal penalty and so forth. And so that has limited the use, for example, of non-encrypted platforms like FaceTime and Skype and that sort of thing, but the government has relaxed those regulations. So we're learning a whole new world of how to interact with patients online and be able to document what we're doing, and trying to understand what works best, how we can meet patients' needs, what needs to be documented, and who really needs to come to campus and so forth. We also are gearing up for what we expect to be a surge of hospitalized patients. So I just, prior to doing this video, got off our daily phone call with our CEO and the other people who work with him, and our logistics people and so forth. We have a brand new health education campus, which is adjacent to our building here, which is set up as a classroom for 2 medical schools, a nursing school and a dental school and that sort of thing. And that has been shut down and is rapidly being converted to a 1,000-bed hospital, a surge hospital, so that as we reduce the number of non-COVID cases, we increase capacity in our regular hospital for accepting these patients. We have increased our ICU capacity, and we're going to use what is meant to be a health education campus as a hospital for patients who are not acutely ill, who don't need to be on ventilators, and who don't need to be in ICUs. We also, like many institutions you can read about on Twitter, are reassigning many people in our workforce, nurses and physicians, retraining them to do things that they are not expert in necessarily, to work in teams led by an ICU type physician, someone who has critical care skills, and all the others of us on the team will provide a supportive role in taking care of these patients who are acutely ill but not ill enough to be in the ICU, or who have been discharged from the ICU and are convalescent.